Hi guys, Dr. Gillard here once again. Let's talk about some anatomy of the esophagus. Now I've been putting this in your GIGU lecture, the first lecture, and I've got to take it out because I don't have enough room for all the pathology. So I'm going to send you over here to watch it. I'm not going to test you on it, but you should really, you have to know this for your boards coming up. And if you don't, you're going to be lost if you don't understand this stuff, and you haven't had it for a while, so I suggest you watch this video. All right, so here we go. Anatomy of the esophagus, because this is preparing us for pathology of the esophagus, right? If you don't know the anatomy, how can you understand the pathology? So esophagus is a neuromuscular tube about 25 centimeters in length. It extends officially from the laryngeal pharynx to the stomach, or you could say it starts about the level of C6 and extends down to the level of T10. It travels through the chest in a region called the posterior mediastinum. And let's just review our anatomy. Here the nose would be right there. There's the lips, chins like that. You guys know how my drawings are, not the greatest. Just to give you an idea of where we are here. So the esophagus actually should start at the level of 6. So here's 2, 3, 4, 5, and 6. Right? So it actually should start up about, this is off a little bit, should start about right here. Remember, it's located posteriorly to the trachea and also posteriorly to the lamina of the cricoid cartilage, which is right here. And so there it is. It's made up of 3 portions. There's a cervical portion, slightly left of midline. It's posterior to the larynx and trachea, as we said. And then there's a thoracic esophagus, which curves a little bit slightly to the right as it goes behind the bifurcation of the trachea. Then, not too excited so far about pathology, but now I'm excited. This is an important piece here. This is the abdominal esophagus. It's very short. It's 2 to 4 centimeters in length, and it is found below the esophageal hiatus. So when the esophagus comes out of the esophageal hiatus, that's the abdominal esophagus. Who cares? Why am I making a big deal about this? Because the abdominal esophagus is an intraperitoneal organ, right? So if you get a perforation from chronic GERD or other conditions, you could develop a peritonitis, which can turn into a septicemia, and you can die from that. So the question, could esophageal pathology ever cause peritonitis? The answer is yes. If you have a problem with the esophageal portion of the esophagus, it could cause peritonitis. Okay, so there's kind of a picture, an A to P view. The trachea is obstructing most of the thoracic or the upper thoracic here. And we can see the most important part for me is where it goes through the diaphragm, the esophageal hiatus of the diaphragm. And the abdominal esophagus would be this piece right here. Okay, that's intraperitoneal. Let's talk about the esophageal hiatus a bit. That's a hole within the diaphragm. It's located about the level of T10. It starts a little to the left and a little bit anterior of the aortic hiatus. We'll take a picture of a cadaver here, or we'll look at a cadaver picture here in a second. So if you're sensitive to that stuff, I mean, this is for my students, so but a cadaver picture's coming. It allows the esophagus, of course, to pass between the thoracic and abdominal cavities. So let's check it out. There it is right there. Right? Esophageal hiatus. Or whoops, that's not which one am I pointing at here? That's the aortic hiatus. Esophageal hiatus is right there. This is S to I view, and there's the caval hiatus for the vena cava here. So we're looking at an I to S view. This is the diaphragm. That'd be the left hemidiaphragm, the right hemidiaphragm. There's the vertebral bodies. Just to get you, there's the, looks like is that rhomboids? I need to see the rest of the picture. But anyway, that's the key parts there. Now, here's a great board question, and great, well, if you're watching this, I won't ask you, this is not testable, but great board question. What is transmitted through the esophageal hiatus? What does that mean, transmitted through? What passes through the esophageal hiatus? Well, of course, the esophagus, then the anterior and posterior vagal nerve trunks, the esophageal veins and arteries, and some lymph vessels. So really easy to make a question with that. It's fortified by the right crus of the diaphragm. So it's kind of lassoed. The right crus is kind of strange. It lassos the esophagus as it passes through there. So it's kind of better statement would be the right crus fortifies the lower esophageal sphincter, and so does the esophageal hiatus also fortifies the lower esophageal sphincter. Let's take a look at this. I said, oh, it's fortified by the right crus. Okay, yeah. So that's correct. It's fortified by the right crus. What about the left crus? No. I was right. Everything I said was right. So the left crus is kind of lazy, right? This is left over here. Here's the left crus. So here's the crura of the diaphragm. But the right one is the star of the show, which is kind of weird. So the right crus comes up and it lassos the very first part of the abdominal esophagus. And it actually acts as a makeshift sphincter. So that's very important. The esophageal hiatus also acts as kind of a sphincter, and both of these help close the esophagus so acid doesn't go back up inside the esophagus. There's 3 narrowed regions. There's one called the immediately below or after the upper esophageal sphincter. It gets narrowed. When it passes behind the left mainstem bronchus, it gets narrowed, and as it passes through the esophageal hiatus, it gets narrowed. So in order for esophagus to be normal, you have to have these functioning things. You have to have a normal upper esophageal sphincter. We'll take a look at that. A lower esophageal sphincter. We'll take a look at that. Coordination of peristalsis. That's easier said than done. That's an enteric nervous system thing. That needs to be working normally. And then you have to have a lumen that is non-obstructed, so you can't have any tumors in there so food can slide through. I could have added you need to have mucus, right? There has to be mucus in there to help the food slide, so your mucosal glands have to be working well as well. We'll look at those. Upper esophageal sphincter is normally closed. In fact, the upper and lower esophageal sphincters are normally closed when food or liquid is, when there's no food or liquid in the oropharynx or laryngopharynx. And it has to, when you have a ham sandwich, you take a bite of it and chew it up and form a ball of that food. That's a bolus. When your tongue pushes that into the oropharynx, it stimulates a little peristalsis, even the oropharynx, that pushes it down. And as it heads toward the upper esophageal sphincter, that has to open up, right? If you have a problem with that, you'll choke and you won't have you have trouble swallowing. You have dysphagia. So what's the deal with this upper esophageal sphincter? Who makes it? There's a muscle called the cricopharyngeus muscle who makes it. And this is out of Standring. That's the big, thick Gray's Anatomy. AKA is the inferior pharyngeal constrictor. Let's take a look at it. So here's a side view of the trachea. There's the voice box, or there's the Adam's apple. Our laryngeal prominens is right there. Thyroid cartilage. Cricoid cartilage, posterior's back here, anterior's here. There's the nose of our little man and his lips. Right, so that's where we're looking at. And so the cricopharyngeus muscle gets the name because it is attached to the cricoid cartilage. So crico, and it makes up the pharynx, so pharyngeus, cricopharyngeus. Not to be confused with this is thyroid cartilage, so this would be called the thyropharyngeus. In fact, we have the meeting of these two pieces of muscle. There's something called Killian's triangle that is formed here. This is a congenital weak spot, or just a weak spot in all humans, some more than others. And some people, if they have high pressures when they swallow, you can actually get a herniation called a Zenker's diverticulum that comes out of the back of Killian's dehiscence or Killian's triangle. We'll talk about that more when the time comes. All right? But right now we're talking about the upper esophageal sphincter is basically the cricopharyngeus muscle, and there it is. Its tone, its normal tone, squeezes the esophagus shut. Good? Okay, what else can we say about the upper esophageal sphincter? It's 2 to 4 millimeters in length. It has motor and sensory nerves like everything else does. There's a glossopharyngeal nerve, and then there's the parasympathetic vagus nerve that controls it. Motor is glossopharyngeal, sensory is the vagus nerve, and it's difficult to really see this thing except with mammometry. What is mammometry? We're going to talk a lot about mammometry in this class. So you have to go to the lab. Your GI doc will order this test. And you stick this wire through your nose, goes all the way down your esophagus, stops right here by your stomach. And it has, along this wire, it has these pressure inducers that can sense the amount of squeeze. When you swallow a tube, of course, you have peristalsis in the tube squeezes progressively down, just like the peristalsis in your stomach. And so you can measure the pressure of the squeeze and see if swallowing is normal. Is there too much pressure? Is there not enough pressure? Is there a smooth primary wave of peristalsis? All that stuff can be answered by using mammometry. So that's the deal with mammometry. Lower esophageal sphincter is super important. It's called the last anatomy. You know it as the cardiac sphincter. That's a strong AKA, but in pathology, never call it the cardiac sphincter. It's always the lower esophageal sphincter. It's not a true anatomical sphincter like the pyloric sphincter, which separates the stomach from the duodenum. That's a true powerful sphincter. This one is not, and that's why it needs some help to make it a little beefier, a little stronger. And that's where the crus and the esophageal hiatus come in. It is actually created by a thickening of the Muscularis externa layer. I'll show you a picture of that here in a second. And it's located at the level of the esophageal hiatus. There it is. Right, so here is the Muscularis propria, aka Muscularis externa layer, and you can see all of a sudden it gets really, really thick and strong. That's the lower esophageal sphincter, and you need that to pinch off this. This is the stomach down here, and you have acid down here. Acid could gurgle up through here and burn your esophagus if this isn't strong and pinched. All right, might as well look at the Z line while we're here. So this is the zigzag line. This is where the stratified squamous epithelium of the esophagus meets the columnar simple columnar epithelium of the abdominal esophagus. So the esophagus really is made up of mainly stratified squamous, non-keratinized, but it's also made up of simple columnar epithelium as well, just this abdominal piece. Where they meet is the zigzag line. The zigzag line should always be at the level of the lower esophageal sphincter. We'll learn in a condition called Barrett's esophagus where you can see it way up here. That means all of this tissue has went through a metamorphosis, and it's actually not good. You can get mutations when it goes through a metamorphosis, and it can become dysplastic and become cancerous. This is called a Barrett's esophagus. A Barrett's esophagus, and that's a precancerous condition. So that occurs when the Z line raises. Now, the other important thing is the gastroesophageal junction. That is not an AKA for the Z line. Not an AKA for the Z line. Got it? Everybody messes that up. That is the anatomical meeting of the cardiac portion of the stomach with the abdominal portion of the esophagus. Okay? It's not a histological, it's an anatomical meeting, not a histological meeting. And it is usually lower than the Z line. Got it? We'll look at these ligaments. I got a slide on that coming. So everything I said pretty much already. Lower esophageal sphincter is wimpy on itself. This thing It's not very strong, so it needs some help. Well, here's the diaphragm. This is the esophageal hiatus right here, and you can see the esophageal hiatus is pretty meaty. So that helps with the closing power. What's not drawn here is the right crust, which lassos this thing and also kind of beefs it up. So it's reinforced by the right crust and the esophageal hiatus. A good question, right? Nice anatomical question for you there. What's the job of the lower esophageal sphincter? We already said it stops gastric contents from regurgitating upward into the esophagus and damaging the esophagus. And then it also can't be tight all the time. It has to be able to relax when food is heading its way. When a bolus of food is coming toward it, it needs to relax. So those are the two things it needs to do. And when it doesn't work right, we're going to look in the next lecture, we're going to look at the pathology, which can occur if it doesn't work right, like the nutcracker esophagus. Normally closed tight, unnatural. Now, what if it's wimpy? What if, and this is the problem in people over 50, it gets, and some of you people as well, it gets too lax. If it gets too lax and it can't pinch off the esophagus, you can get gastric fluid bubbling up or burping up or regurgitating up into your esophagus, and that three-layered, we'll look at the histology of that, the epithelium, but it's not a strong epithelium. It's only 3 layers thick, so you can burn it. You can get into the lamina propria and it can start bleeding and causing ulcers and things like that. And that's called gastroesophageal reflux disease, or GERD. Very, very common problem of the humans. One of the most common things, pathologies. We'll talk a lot about that when the time comes. And the GERD can turn into a Barrett's esophagus, as we said, which is precancerous. That can become cancerous. How do you keep the cardiac orifice of the esophagus closed? Well, so how do you keep, AKA cardiac orifice? I threw a curveball at you. Remember, that's the same as the lower esophageal sphincter. Well, you got to have a healthy esophageal hiatus, and you have to have a healthy and firm lower esophageal sphincter, and the right crust has to have good tone to it as well. You need those things to make to not have GERD, basically. Together, they do a pretty good job at closing off that esophagus. What holds the esophagus in place? How come we can't slide the esophagus up into the thoracic cavity? Well, we can, and that's called a hiatal hernia, and that's a problem. But normally, people don't. That doesn't occur because there's some very strong ligaments that run between the diaphragm and the esophagus. Therefore, they're called phreno. That's kind of the Latin word for diaphragm, and esophagus is esophagus. So phreno-esophageal ligaments are very important. Let's take a look at them. The really important ones are these upper fibers of the phreno-esophageal ligaments. So picture if you try to pull this esophagus upwards, these guys will stretch tight and prevent it from sliding up. That's great, but what happens when you get old, 50s or so, things start drying out and getting lax and breaking down, and these can snap or get really limp. And you can literally pull your esophagus into your thoracic cavity, and you can also pull the lower esophageal sphincter into the thoracic cavity, and therefore it loses the support of the esophageal hiatus and the support of the right crust. In other words, you can't close your esophagus. People with these sliding type hiatal hernias, they get GERD. They're guaranteed to get GERD because you can't close off your esophagus. And so that's a common cause of GERD is people with hiatal hernias, which we'll talk about when in the future. I know I say that a lot, but it's true. We do. I like to kind of plant seeds in your brains to get you thinking about things. So when I say in the future, when I talk about it, you go, oh yeah, I remember you talked about that. All right. Zigzag line we talked about. It's the histological junction between the abdominal esophagus and the main part of the esophagus. It's made of non-keratinized stratified squamous epithelium and a little bit of simple columnar. The esophageal portion is simple columnar epithelium. It's typically at the level of the lower esophageal sphincter. We've already looked at it. We've already talked about it. We've also said that the gastroesophageal junction, aka esophageal gastric junction, is not the same as the Z line, right? People, no matter how many times they say that, you guys get messed up on that. It's the anatomical meeting place of the abdominal esophagus with the stomach, the cardiac region of the stomach. We've already covered that. What does the lower esophageal sphincter look like endoscopically? Well, because it's naturally closed, it's pinched off, and you have these folds where the esophagus buckles in. Those are called gastric folds. So here's a very good example of gastric folds. We have an endoscope. We have a little camera going down the esophagus, and it's coming to this region, and you can see the folds. We know we're at the lower esophageal sphincter when we see this, right? The middle of the esophagus is still open, but not down here. What else do you see? As I take some water, look at that. Tell me what do you see? That cancer? No, that's the Z line. The Z line never looks like a Z, right? Does it? It doesn't look like a Z at all. But that's what it looks like. Is this a normal Z line? Yeah. This is smooth. Even though it's smooth, you can see the color different, and it's at the level of the lower esophageal sphincter, so it's where it's supposed to be. What if I put on a test, what if I put number 1? What tissue is that? Well, we know that if we go through the hole here, we're going to be down in the stomach region. So this tissue right here would be simple columnar tissue, simple columnar epithelium. What tissue would this be? Number 3, we'll say. That's the stratified, non-crotinized, stratified squamous epithelium of the esophagus. Got it? How about another one? Yeah, those are the gastric folds. The esophagus in a patient with GERD, it's not completely closed, is it? It's a little bit open. But the Z line looks good. It's at the level of the folds. Everything looks good. What about this patient with chronic retrosternal chest pain? Oh, this is no good, is it? See the folds down here? There's the lower esophageal sphincter right in this region. And the Z line is way too high. Look, it's come way out here. This is called a Barrett's esophagus. So this tissue has morphed from squamous into columnar, the same kind that's in the intestine, actually. And it's got goblet cells in here, and this is precancerous. Really, technically, it's precancerous, because this can morph one more step into dysplastic dysplasia, and that can morph into cancer. Histologically, so it's important to watch this video for this reason alone. I'm not going to cover this when we get into the stomach and then the small intestine, large intestine, because it's all about the same. But let's go over the histology of the esophageal wall, and it applies to everything else. The stomach has one extra layer in the mucosal externa layer, and that's an oblique layer. But everything else is the same. So the very innermost layer is the mucosa, and that's made up of an epithelium, a lamina propria, and a muscularis mucosae. The stratified squamous, non-crotinized stratified squamous, that's the epithelium. That's made up of individual epithelial cells, make up the epithelium. Right? Then we have the submucosa. We'll look at all these a little more specifically. Then we have the muscularis externa, which has got some muscle, the adventitia, and yeah, let's get into this. So here's a nice picture of this. There's the lumen. When I talk about the lumen, this is where the food slides down. This is the intestinal wall. The whole ball of wax is the intestinal wall. But here's the layers. So we have a mucosal layer, which has 3 subdivisions, an endothelium, lamina propria, mucosa, muscularis mucosae. So the pink, you can't see the individual cells, but there would be individual cells here making up the stratified squamous. That's pink. That's the endothelial layer. Deep to the endothelial layer, we have the lamina propria. That's the interstitium, right? This lamina propria is the interstitium. There's blood vessels. Look at the blood vessels in the lamina propria. And there's microcirculation. There's nerves in here, as we'll see in a second. So it's important. Once we get past this dark blue layer, now we're in the submucosal layer. That's where Meissner's plexus hides. So that's an important concept. Once we get past this light kind of pinkish layer, now we're in the Muscularis externa. Don't get that confused with Muscularis externae, or Muscularis mucosa confused with Muscularis externae. They're different animals. And the AKA, that's Muscularis propria, AKA just Muscularis. That's the muscular layer. That's where peristalsis is generated here. In everywhere else except the stomach, there is an inner circular layer. C means center, means it's closer to the center of the esophagus is how I remember it. And there's an outer longitudinal layer. And I don't know how to memorize that, but I remember the circular layer is the one that is on the inside. And there's the circular layer in pink, and there's the longitudinal layer in red. Right? And that's where Auerbach's plexus is. All right, so mucosal layer, kind of talked about it. It lines the entire length of the esophagus. It's made up of mostly non-keratinized stratified squamous epithelium. The abdominal esophagus is made up of simple columnar. We already said this. I could probably get rid of this slide. Here's the weird thing, though. Unlike the skin, hirsute skin, right, you have only 3 layers. So you're missing the stratum granulosum. So it's not as thick as the skin is. The globular skin right here, that's even got 5 layers, right? That's got stratum lucidium. That's got an extra layer. This doesn't have stratum lucidium. And so 5 layers, 4 layers. Down the esophagus, 3 layers. They're all stratified squamous. Got it? And we said it's missing stratum granulosum. From inside out, stratum basale, it's got to have that. Those are basal cells or stem cells, right? They make the keratinocytes. And then stratum spinosum is normally the next layer up. Then we miss the stratum granulosum and go right to the stratum corneum. These cells don't slough off, though, to my understanding. Right? What does it do? Well, protection is one thing. It protects, everybody burps up a little acid, so it offers 3 layers of protection from acid. But it also is a support system. It supports or confers lubrication. So we're going to look at the glands that secrete mucus, and the mucus has to sit on something, so it sits on top of the epithelial layer. So it confers lubrication and protection. Got it? So it also has tight junctions, right? The cells have to be held together by something. So we have junctional complexes. You've had these in histology, also known as CAM, cell adhesion molecules. So we have the tight junctions, which are responsible for stopping acid from sneaking down between cells. They're not very good at holding the cells together, but they're good at stopping acid from sneaking down. Then we have adherent junctions. Those hold cells together, but not as good as desmosomes are the kings. Desmosomes hook right into the cytoskeleton. There's also a glycoconjugate material that fills the space, the intracellular space, soaks up some of that acid if it gets down there. Glycoconjugate would be right in this region. That's in between the cells. Here's the tight junctions. Their job is to stop. Here's some acid molecules coming down. Blocks it. If the acid gets through here, it goes right through these guys like nothing. But here's your zona adherens here. But here's your strong ones, your desmosomes, which are on the sides, the tops, and the bottoms of some keratinocytes. But notice they're hooking right into the cytoskeleton, which, I mean, these black lines would go all the way through the cell, right? You guys know this stuff. There's a smooth-looking, beautiful esophagus in endoscopic view. Are we at the lower esophageal sphincter? Grab a little water while you ponder that in your brains. No, we are not. No, we are not. Lamina propria, we said that's underneath the epithelial layer. And it's like an interstitium. That's where food and oxygen and such has to swim over to service those epithelial cells. They need nutrients, right? They're living tissue, so that has to be serviced. They contain tiny blood vessels and capillaries and nociceptors. Let's take a look at it. So I drew them in here on this drawing. There's our lumen, right? These first three layers, that's the mucosal layer. We talked about this inner pink layer. That's the epithelial layer. That's the three layers of cells, the stratified squamous cells. Minus stratum granulosum is not there. But then we get into the interstitium, which is the lamina propria. And we can see there's arteries, veins, and we have nerves. Therefore, if you get enough acid, it doesn't take much to get, all you got to do is rip through that epithelial layer, and you're in the lamina propria here, and you can float over and burn one of these nerves and set off the pain of heartburn, right? So it's pretty easy. When we get in the submucosal layer, there's much bigger nerves, and you can really get in much bigger vessels. You can get a much more serious bleed and pain, but you can definitely get heartburn, and that's what heartburn is. You're stimulating. When you have heartburn, that means you have ripped, the acid is ripped through the epithelial layer. It's in the lamina propria and burning these nerves. Okay, the blue layer here, that's the muscularis mucosa. It might help a little bit. It's made of smooth muscle, but it's pretty wimpy compared to the circular longitudinal muscles here of this next layer. We're going to talk about the submucosal layer. That is made of dense irregular connective tissue. It contains much bigger nerves and blood vessels and capillaries, so it can generate more bleeding and more pain. I didn't draw everything in, but I drew these blood vessels are much bigger here in the submucosa in this light pink area. It also has our first nerve plexus. I don't know if they're trying to make that the nerve plexus or not, but that's where Meissner's plexus is. I remember Meissner, if this is the outside world where the sunlight is, there's Mr. Sun. I always think of which one's Meissner's and Auerbach's plexus, which one's deeper. Misers hide in the basement and count their money. So misers are deep in here. So Meissner's plexus would be in the submucosal layer. There are submucosal glands. There's actually glands we didn't talk about yet in the lamina propria as well. Just toward the distal end of the esophagus, there's some cardiac glands that secrete mucus. But in all layers, we have some esophageal glands, submucosal esophageal glands, sometimes called esophageal glands proper, which are in the mucosa, and they spit out a lubricating mucus, which sits on top of the epithelial cells. They also spit out some bicarbonate and some epidermal growth factor to if you did burp up some acid and damage has occurred, this helps repair the situation here. The bicarbonate is secreted to help combat acid as well, kind of neutralize some of that acid, hydrogen ion that comes up. There's a nice histological picture of a esophageal gland. The duct isn't shown. The duct went deep into the plane of the page, but it would go right up like that. And that's where the mucin mixes with water to form mucus, and then there's the epithelial lining, and the mucus would sit right on top of the lining, and it would help food slip right on down there. And as I said, the cardiac glands are actually in the lamina propria, so there's mucus glands in the mucosal layer and in the submucosal layer in the esophagus. These are only in the distal region down by the lower esophageal sphincter is all, and they secrete mucus to give us a little extra protection, because if acid's going to be burped up, that's where it's going to go the most. Submucosa also has, as we said, the part of the enteric nervous system, which is Meissner's plexus, and it's not, in humans, it's not very well developed, so they don't think it really helps much with regard to coordinating peristalsis. And what else do we need to say about that? That's about it with that. Not too exciting. Here is a esophagus kind of peeled back, and you can see Meissner's plexus, also called the submucosal plexus. Probably not going to say that on the boards because that tells you exactly what layer it is. One of the questions would be, where do you find the Meissner's plexus? They're not going to say, well, where do you find submucosal plexus? Well, it's in the submucosal layer. It's too easy. They'll say, where are you going to find Meissner's plexus? It's actually in the submucosal layer itself. Muscularis externa, that's the meaty muscular layer of the esophageal wall, as we already said. It contains circular muscles. C means toward the center. And it contains an outer layer, or that's another word. The O in longitudinal means outer. It's easier to remember circular is toward the center. That is responsible for, it's part of the enteric nervous system. It's mainly responsible for controlling peristalsis, for pushing that bolus of food from your laryngopharynx all the way down and dropping it into the stomach. And we'll look about problems. There's bugs that can go in there. There's degeneration that can occur. People can have swallowing problems because of that. It's also weird because histologically a weird zone. You've probably guaranteed Dr. Doe has asked you this question. The muscularis externa, the upper 1/3 of it is actually not made of smooth muscle. It's made of striated muscle. You still have the same layers, but it's not smooth muscle. The middle third is a mixture of striated and smooth muscle. The lower 1/3 is pure smooth muscle. Auerbach's plexus, also called the myenteric plexus, lives in this layer. Specifically, it's between the circular and longitudinal muscle. And this is very important for coordinating peristalsis. You get a bug in there and it causes an inflammation and you knock Auerbach's plexus out, you're going to have trouble swallowing food. And there it is right here between the circular toward the center muscle, and there's the longitudinal on the top. And the yellow, that's Auerbach's plexus. Peristalsis is an important concept. Remember, primary peristalsis, that starts when food enters the esophagus, the upper esophageal sphincter releases and relaxes, and a peristaltic wave continues from the laryngopharynx all the way down. It's one shot. This primary peristalsis does not go backwards. It's one. If the food doesn't get pushed along, too bad. It's just like one continuous wave. Hopefully it'll push the bolus of food into the stomach. It takes about 8 to 10 seconds or so. Standring says 5 to 8 seconds. And sometimes liquid can actually beat the peristaltic wave if you're upright and have gravity helping you. So it's a fairly slow turtle, actually. Secondary peristalsis, what if you ate something and you, for whatever reason, you didn't swallow it all? Some of it got stuck right in the thoracic region of your esophagus, right in the middle. What happens? You do not start primary peristalsis again. That'd be a waste of energy. You will let's let me draw it. Here we go. Heaven forbid. He's going to try to draw again. There's the esophagus. I guess I'm into drawing noses today. Here's your mouth. Oh my God. Right, so food is starting here, going that way. Here's your stomach down here. If the food gets stuck here, secondary peristalsis is not going to start way up here. Primary peristalsis starts way up here by the upper esophageal sphincter. Secondary peristalsis will start upstream right here. So you get a contraction of the smooth muscle and it'll go all the way down like that. If the stimulus is still there, if the food hasn't moved, you'll get another one. Pushes it down, and another one, and it can go over and over and over until this food or acid is removed. The same thing, if you get acid that's burped up into here, peristalsis will start here and try to push it out. So that secondary peristalsis is actually really, really important. It can get so strong each time it tends to get stronger and stronger. It can start to cause pain. So you can get the feeling of odynophagia. And we'll talk about those in a second. Odynophagia is not pain, though. That's an abnormal, it's like you feel something weird, like you're not swallowing. It doesn't flat out hurt. If it flat out hurts, that's odynophagia. If it's just trouble swallowing, it's dysphagia. Probably messed that up a little, but that was true. Dysphagia is messed up, no pain. Odynophagia is flat out pain when swallowing. All right, we said the secondary peristalsis is important for clearing the regurgitant fluid, stomach contents out. And yep, Auerbach's plexus, cranial nerve 9, cranial nerve 10 are all involved in this reflex, this system. Meissner's isn't that developed, we said, right, in humans. Might help a little, but not much. What about pain? What causes the actual pain of people getting heartburn? I kind of said this, but you're stimulating the chemoreceptors and nociceptors that live in the lamina propria, or the submucosal layer. And it's probably because acid has burned through those three epithelial, or those 3-layer thick epithelium, and gotten into the lamina propria. We don't have to go far to cause pain. But there's another cause of pain, mechanoreceptors. So if you do get a blockage, like let's say this bolus of food, you have stenosis, a stricture, which we're going to talk about next. It's a beaver dam here, and you can't get food through there very good. The esophagus stretches, and the stretch stimulates mechanoreceptors to signal pain as well. But the pain is not very good. The brain is not very good at telling you where this pain has come from. In fact, it's described as a referred pain because the brain is getting these signals. Okay, this is sending, these mechanoreceptors are stimulated. They're sending a signal up to the brain, but they're traveling through the ANS pathways, and the ANS pathways is not very accurate. So the brain goes, huh, what are you trying to tell me? Oh, you have pain, but you're not telling me where the pain's coming from. I think it's coming from the sternum. So most of the time, patients get pain over their sternum. They might get pain right in the throat, but more likely they're going to get pain referred down to the sternum. Okay, so that's kind of the deal with that. It's considered a visceral type pain, which is the brain has a terrible time telling where that comes from. It's coming through ANS pathways, we said. It's not very good. The brain, everything I just said, and the brain gets confused as to what's generating the pain. And usually it says it's coming in the sternal region, the retrosternal pain. Like it's coming right under my doc. It feels like it's right underneath my sternum. Could be chest, could be over in the heart region. It's often mistaken with a myocardial infarction. It's difficult to tell apart. Could be down in the xiphoid region. Usually xiphoid pain in the epigastric region, you can also say. That's usually where stomach ulcers and problems with the stomach usually refer pain to the xiphoid region. But esophagus can do the same thing. Maybe it's in the lateral posterior chest, like pneumonia would show up. So it's not very good. Esophageal pain can be referred to different places. All right, so that's enough. We'll start talking about the pathology for real testable material. So make sure you read this. So I think this is a good review, and it will give you a better understanding when we talk about the different pathological mechanisms which cause dysphagia and odynophagia. All right, see you in the next video.